the modalities and the acquisition has to be really very fast so as to give a good picture of the anatomy and the abnormal pathology in cardiac diseases. When we talk about current trends in cardiac CT, it is important to understand that for last few decades, the war or the advances in machine was mainly based on slice war. It was kind of slice war. The machines were trying to acquire more and more slices in a given amount of time. But now gradually the slice war has reached to a particular limit, and now the war is replaced by dose war. That is, at the same radiation dose, which machine is able to generate a better quality picture or a diagnostic quality image. But the slice war is no longer valid. Now it is replaced by dose war. This is because the CT, cardiac CT, gives more radiation to the patients, and therefore it is important for the machine or the cardiac CT to get the same image quality at a lesser radiation dose from patient safety point of view. So therefore, it is important for cardiac CT to be able to provide diagnostic image at a lesser radiation dose. Another important recent trend in cardiac CT is the myocardial perfusion with CT, which is now being commonly performed at few centers, and that is a current trend which is gaining momentum. Another important thing is that as in AI is or artificial intelligence is finding place in different applications in clinical practice in radiology, so cardiac CT is also not an exception, and we are seeing increasing use of artificial intelligence in cardiac CT as well. Another important tool from cardiac CT point of view is the spectral CT, which is a dual CT, which is also being used with varying degrees of benefit for cardiac CT. And a very important application which is also evolving in cardiac CT is procedure planning, that transcatheter aortic valve replacement or transcatheter mitral valve replacement. So these are being increasingly, cardiac CT is being increasingly used to plan these procedures. So these are the important current trends, and for the basic and the advanced clinical applications in cardiac CT, we have none other than Dr. Sandeep Vora, who is a consultant radiologist at Indraprasth Apollo Hospital, New Delhi, and Dr. Sandeep Vora is a consultant radiologist at Indraprasth Hospital, New Delhi, and he has extensive experience of more than 15 years working with CT, and he is an excellent teacher. He loves to teach about the cardiac CT applications to resident doctors and at different radiology forums. He has extensive experience in cardiac CT imaging for last many years. So we look forward to Dr. Sandeep Vora in this session as we go ahead. And apart from that, the second session will be on MR imaging in cardiac MRI, where we will mainly discuss about the fundamental aspects and few basic points about the cardiac MRI. So cardiac MRI is also very useful for myocardial perfusion, myocardial viability, and there are a lot of very important points which decides, which helps in clinical use in acute myocardial infarction as well as for cardiomyopathies. It is important for students as well as for radiologists who are doing cardiac imaging to understand very basic points, the basic fundamentals of bright blood imaging, the dark blood imaging, how parallel acquisition helps in faster image acquisition for cardiac MRI, how to improvise the image quality in cardiac MRI, what are the basic principles of dynamic first pass perfusion to decide myocardial viability and perfusion. Similarly, there are new applications like ASL, which is a without giving any contrast, you are able to evaluate the perfusion in the myocardium, as well as the diffusion weighted MRI, which has found to have role. So for cardiac MRI, which is going to be the second lecture in this session, we have none other than Dr. Bhavin Chankaria, who is a very well-known consultant radiologist from Mumbai, and everyone knows him as a very good radiologist for cardiac imaging as well as for a lot of other body areas. And his well-known course, that is Radiology Education Foundation, is very popular, and you will never find a radiologist who is trained in India and he has not attended this course of Radiology Education Foundation or REF. So we look forward to this session on cardiac MRI by Dr. Bhavin Jankaria, who loves to teach and who is very passionate about cardiac MRI. So let's start with our first session on cardiac CT, where Dr. Sandeep Vora from Indraprasth Apollo Hospital, New Delhi, will talk about few basic points about cardiac imaging, coronary CT, angiography, and few advanced applications as well. So Dr. Sandeep Vora, may I invite you? Thank you.
Good evening, everyone. Thanks, Dr. Nitin, for those kind words of introduction. I welcome you all to this webinar on cardiac imaging. In the first half of around 25-30 minutes, I will take you across what is happening right now on coronary CT, our experience of dealing with cardiac CT for past few years, and then you will have another lecture by Dr. Bhavin on cardiac MR. Now, cardiac CT has been one of the fastest growing non-invasive diagnostic cardiac imaging modalities in recent times. The journey of cardiac CT began with 4 or 6 slice systems early in the 2000s, and then it shifted on to the 16 slice, 64 slice, and now 128, 160 slice systems. But actually, it were the 64 slice systems which made cardiac CT a modality of choice for imaging of the coronary vessels. But since the last decade, a lot of other changes have happened on the front of cardiac imaging. Some vendors have shifted on to widening their detector boards and bringing in 256, 320, and now a 640 slice system. The other vendors have shifted on to producing dual source scanning, in which 2 X-ray tubes are placed perpendicular to each other. And another shift has been introduction of dual energy CT, whereby 2 X-ray tubes are placed and they emit X-ray beams at 2 different kV. And the other development has been the advent of flat panel CT, which has significantly improved the spatial resolution. Now, the heart of cardiac CT, or the equipment, is the voxel, which is the voxel in the detector, and it is a true 3D voxel, which has an isotropic resolution which is equal in X, Y, and Z axis. And on a 64-row detector system, this is how the voxels are placed along the patient length. Now, there are some key technical parameters that you must be aware before you jump onto the coronary scan. The first and foremost is temporal resolution, which in true sense means that the time which is needed to acquire the scan. And on classical single energy multi-detector systems, it was directly proportional to the gantry rotation time, and it was half the gantry rotation time. Initially, all the equipments were having a gantry rotation of 400 milliseconds, which later on shifted to 350, 330, 300, and now I see a lot of scanners with 270 millisecond of tube rotation time. Another important way to image coronary arteries has been the segmented reconstruction softwares, and multi-segment recons are always preferred as they lower the temporal resolution or the time which is needed to acquire a scan. There has been a lot of advent into increasing the scan pitch without losing image resolution. The second concept is high spatial resolution, which means that what is the 2-point resolution as far as the coronary scan is concerned, and the main factor determining the spatial resolution is the detector design, is the slice thickness at which you work, and then there are a lot of iterative reconstruction algorithms that have been incorporated into systems to improve the image quality and keep the radiation dose low. Patient motion is not much of a factor now with the advent of high-end multi-slice equipments. Now, there have been certain developments in cardiac CT recently. The 128 and 160 slice scanners usually have 64 or 80 row detector systems. However, a lot of vendors have shifted to 256, 320, and 640 detector systems, which eventually use 80 detector row multiplied by 4 or 6 times as the case may be. The gantry rotation time has reduced. Another major shift into cardiac CT has been the dual source scan, in which 2 X-ray tubes are placed at perpendicular to each other, and the dual energy CT uses the two differential energies being emitted either through a single source or a dual source and improving the tissue contrast resolution. On the software front, there are a lot of iterative reconstruction algorithms that have been placed. In Toshiba, it is called IDER. In Siemens, it's called IRIS. In Philips, it's called IDOS. All these softwares do is bring down the radiation significantly and reduce the noise in the image and improve the overall signal. Another major shift that has happened in last decade is specific plaque imaging softwares have come in, which help in quantifying and assessing the plaque morphology, which now plays a big role in management of coronary artery disease. Apart from the structural imaging which these modalities offer, there are new dynamics of functional imaging that are coming into the coronary CT. And the most important of them is the FFR, or the fractional flow reserve, which is calculated on CT. And another is myocardial perfusion, something similar to what we all see on the MR images. Now, inherent to the cardiac CT, we must understand, is an ECG gating that is done along with the scan. On the conventional 16, 632 or 64 row scans, the scan was acquired during the entire cardiac cycle, and the radiation was, equal amount of radiation was given throughout the ventricular systole to the diastole and again to the systole throughout the cardiac cycle. This led to a lot of radiation dose during a coronary scan, typically of 11 to 12 millisieverts. The second concept which came is giving a retrospective ECG gated scan. However, the radiation was controlled through a tube modulation during the ECG acquisition. So the less radiation was given during the phase of ventricular systole, while larger radiation was given especially at the time of ventricular diastole. Now, it is very important to understand when you are doing coronary CT, you need to acquire an image of a coronary vessel which is in rapid cyclical motion. And the time when the vessel will be in least motion is the time when there will be ventricular diastole. So this is the time when majority of the equipments expose maximum radiation to get a clean static image of the coronary vessel. Another shift in technology has been acquiring scans in a prospective ECG gating. Now this is possible, this is also called a step and shoot scan. This is possible across all single source multi-detector scanners, typically at pulse rates below 65 or 70 beats per minute. Now it is very important to control the pulse rate to get this scan, as in this, the equipment gives radiation to the patient only during the time it is acquiring the scan, while at all other times there is no radiation which is emitted to the patient. Now this technique works only if the pulse rate is below 70. On majority of the scanners, if the pulse rate shifts for more than 70 and reaches 80, or the pulse rate fluctuates, the equipment automatically shifts onto an ECG modulated retrospective ECG gating. And it has been presumed that the radiation dose to a patient almost doubles if the pulse rate skips or shifts higher. And another third is, which is usually seen with dual source or dual energy scanners and in machines which have a 320 or a 640 slice scanner. Since the Z-axis resolution, Z-axis coverage is very high, you can always do a prospective ECG gating within a single cardiac cycle. So actually there is no table movement that is occurring, as you see in this case. Only the scan is acquired in a single cardiac cycle. Now the common indications for doing a cardiac CT is evaluation of the coronary arteries and evaluation of the structural heart. The foremost importance of indication in imaging for coronary arteries is evaluation of coronary calcium. Look at the coronary arteries, evaluate patients with bypass, with stents, and look at the anomalies. And this is the area which we will deal mainly in our today's presentation. Now, who all need a coronary CT? Patients who are asymptomatic but have risk factors which could include family history, dyslipidemia, diabetes, smoking, or they have some of the stress test or an echo which is positive for subclinical ischemia, or patients who are undergoing a prior major surgery and need to rule out a significant coronary artery disease. Another subset of the patients are patients who are symptomatic, who have chest pain or who are breathless or who have atypical chest pain. CT also has a very important role in scanning of these patients. It can also play a role in interval evaluation of coronary artery disease. in patients who refuse catheter coronary angiogram or in scenarios where it is contraindicated. It can also be used as a problem-solving modality in patients with coronary artery anomalies if you need to clarify patients with findings with an invasive angiogram. And CT now serves to be an accurate, cost-effective, patient-friendly tool in diagnosis of coronary artery disease. A word about patient preparation. It is something similar to what you do for all contrast examinations. You have to call patients nil orally, ask the patients to hydrate themselves very well. This is key to prevent contrast-induced nephropathy. Always get renal function tests done and use contrast only if the creatinine clearance is more than 60. There is a special indication that if the patient is on metformin, it should be stopped 24 hours prior to the examination. The ideal pulse rate for a coronary scan is 60 to 65 beats per minute. If you think it is more, then you can give a routine beta blocker. In our practice, we usually use 25 or 50 milligram of metoprolol. You can add an Alprax to it just to reduce the patient's stress, and you should always check the pulse and BP after 20 to 30 minutes. Please remember, do not give beta blockers if the systolic blood pressure is less than 100. And you must counsel the patients about the procedure that you're going to do. I know on majority of the newer equipments, this may not be a concern, but if you have an electrical noise, if your ventricular diastolic phase is not constant, your image clarity or spatial resolution will not be good. So it is always advisable to check for an electrical noise, and this is how a typical ECG wave should look at. Because after all, you want to acquire a nice scan during the first phase. So once you have set in the patient, you do a topogram and plan your scan from the carina till the lower border of the heart. Now, typically, non-contrast images are obtained to begin with. There are three advantages that these images serve. First, they give you an idea about the presence of or absence of calcium in the coronary arteries. You can see how nicely the coronaries are seen. It gives you an idea that majority of the calcium score scans are obtained at 75% of the RR interval. It also gives you an idea, is the patient following the breath hold command? And you can almost always check the origin of coronary arteries. I keep telling all the techs that once you do a non-contrast scan, do look at the origin of the coronary arteries, because sometimes if the coronary arteries are arising higher from the aorta, you may totally miss the origin of the coronary vessel. Now, once you have settled down, you can start your scan and you can always reduce your FOV down. All contrast images are performed using an 18-gauge cannula. 4 to 5 ml of contrast is given per second, and the total volume of contrast that is needed is usually 70 to 80 ml of contrast. It should always be followed by a saline chase. Now, it is up to the institutional practice what contrast they want to use. We have always used either 320 or 350 milligram of the contrast. We have never used 400 milligram in our practice, and we have not tried using 270 Visipeg that is available. There is an advantage of using isoosmolar contrast, as the patient's feeling of sensation of warmth or heat in his veins is always less if you are using isoosmolar contrast. And all the multi-slice scanners now use a bolus tracking technique. If you have to perform a triphasic protocol, which could include a special setting if you want to look at the septal thickness, LV wall motion abnormalities, or you want to do a triple rule out of scanning for coronary and the pulmonary arteries and aortic dissection, you can always follow this triple phase protocol, which typically involves injection of contrast followed by injection of a diluted contrast in a 80-20 ratio and followed by the saline chase. Now, what is the hallmark of a good scan? You should always have a clear and sharp images of delineating all the coronary vessels. The imaging should be free from breathing or irregular artifacts, and there should be good enhancement of the coronary vessels. What do you mean by good enhancement? The average density in the coronary should always be more than 300 ounce-field units. And if you look at the scan from top to bottom, there should not be a drop in density of more than 150 HU. Now, before we set in with our 3Ds and scan evaluation, it is always a good idea to look at the coronary arteries on an axial image. You can MIP them, but the key point is do not MIP your images more than the vessel wall diameter. So a typical coronary artery is around 2 to 3 mm, and these are 0.5 millimeter scans. So you should always MIP say around 1 or 1.5 if you want to see the scan quality or the image anatomy. There are two coronary arteries which arise from the left anterior and the right anterior aortic cusp. The left coronary artery rises from the left aortic cusp. It divides into anterior branch which is called the LAD and a posterior branch which is called the left circumflex. By definition, LAD always moves into the interventricular groove and never exits this groove. The first branch which is to the left of the interventricular groove from the LAD are called the diagonals, and from top to bottom they can be called diagonal 1 or diagonal 2. All the branches which arise from the medial wall of the LAD are by definition called as septal branches. The circumflex moves into the atrioventricular groove, and the first branch that comes out of the LCX are called the obtuse marginal branches. And as you go down, you can see the LAD going down into the cardiac apex and even turning behind it. Whenever the LAD crosses the cardiac apex, it's called a type 3 LAD. Right coronary artery arises from the right anterior cusp. It gives a first branch which is called the conus branch. In 50% of the cases, SA nodal branch may also arise from the RCA. And then as you go down, the RCA ascends into the atrioventricular groove, behind into the crux of the diaphragm, dividing into PDA, the posterior descending artery, and the posterior lateral ventricular branch. Now, in majority of the patients, RCA supplies the base of the heart, and when the system is called right dominant, in 10 to 15% of patients, circumflex supplies the base of the heart and it's called left dominant. And if both of the vessels supply in equal proportions, it's called a codominant system. Now, what do you mean by atherosclerotic plaques? Coronary plaques are defined as structures which are 1 millimeter square, which lie within or adjacent to the artery lumen, and they are clearly distinguishable from the vessel lumen and always surrounded by the pericardial tissue. If you look at the histology of the coronary plaques, majority of the plaques begin with as a neointimal thickening or a hyperplasia, which can progress to form a fibroatheroma, which can have a thin or a thick cap. The fibroatheroma can undergo ulcerations or rupture. If the plaque is soft, it has a rich lipid core. In other situations, the plaque can solidify and develop spotty calcifications and finally may mature into a calcific plaque. In some scenarios, this whole process may not be seen and the plaque may directly calcify into a nodular area of calcification. Now, what are the plaques that you see on CT? Typically, you see three categories of plaques. The first ones are called non-calcified plaques, which have an average density of less than 140 Hounsfield units. These have been further divided into two categories, which are called lipid-rich plaques, which have typical densities varying from -30 to 60 HU, and fibrous plaques, on the other hand, which have densities of 60 to 140 HU. Plaques which have density of less than 30 HU have been termed as low attenuation plaques. Calcified plaques, on the other hand, have densities of 140 Hounsfield units, and to classify a plaque as a calcified, at least 50% of the vessel plaque should be calcified. If you have mixture of both these, they are typically called mixed plaques. Now, what is the advantage of looking at a plain scan and doing calcium scoring at the first go? Presence of calcium in a coronary artery is a direct sign of atherosclerotic disease. You can grade it using an Agatston score, which quantifies what is the volume and what is the total score. Patients who have usually scores of more than 400 have more likelihood of coronary artery disease. There is a lot of work that has been done on looking at calcium score alone, and it has been advised as a gatekeeper for advanced testing, and it remains a very powerful mediator for lifestyle change. Points to be noted are that if a patient has a calcium score of 0 and he's in a low to intermediate risk category, the finding almost always rules out a flow-limiting coronary artery disease. And there are some AHA guidelines which recommend usage of coronary artery calcium score as an adjunct to traditional risk stratification models. And it has been advised that you do not need statins in patients who have a 0 calcium score. There are some articles which have given a warranty period of 15 years for the patients to develop CAD if the calcium score is 0. However, if the patient comes to your OPD or the cardiac clinic with chest pain, 0 calcium score has no value. And you must always give contrast and proceed with the contrast CT angio. In patients who have a moderate to high risk for coronary artery disease, a CAC alone has no value. And in symptomatic patients who have calcium, it usually suggests that there will be an obstructive lesion. And patients who have calcium score of more than 1000 usually have a significant coronary artery disease and can develop non-fatal or MI in future. There is a lot of controversy. It's an individual institutional protocol whether to scan patients with higher calcium scores. We usually at our hospital do not do scans for patients with calcium score more than 1500, and especially if the plaques have been scattered. uniformly in all the coronary vessels. If you have a single blob of calcified plaque in a proximal vessel, it is better to take the patient for a catheter angiogram. Now, coming on to another subset of findings which has been seen recently, commented a lot on CT images, is vulnerable plaque. What is a vulnerable plaque? 4 categories of plaques have been classified as vulnerable plaque. Plaques which have positive remodeling, which show low attenuation, which have spotty calcification, and which show a napkin ring sign. These 2 plaques which show positive remodeling of the vessel or have low attenuation are most helpful in predicting future coronary events. Now let us see some examples. Now you can see a soft plaque, a lipid core plaque, which is increasing the vessel wall diameter. This is a classical example of a positive remodeling of the vessel wall. And by definition, if the outer vessel wall diameter is more than 10% of the native vessel below or before it, it's usually classified as positive remodeling. And a remodeling index of more than 1.2 is considered significant. Napkin ring sign, on the other hand, is an enhancement of the outer margin of the soft plaque, which is narrowing the vessel lumen, as you can see, and this is the lipid-rich core with an enhancing capsule. So this finding has been classified as napkin ring sign. Spotty calcification means a mixed plaque with spots or specks of calcification. This has histologically been labeled to as quite consistent with findings of microcalcification on intravascular ultrasound. Spotty calcification can be small or large or intermediate, but typically by definition is always less than 3 millimeters in diameter. And you can also have low attenuation plaques with a tiny lipid core. Now here comes the game of spatial resolution on CT images. These plaques may be better appreciated on high detector scanners or dual energy scanners because of inherent specific tissue contrast resolution that you can see on those CT machines. And you can also have ulcerations in the plaque, which is because of the erosion of the lipid core of the plaque because of the flowing blood in the vessel. There are a lot of semi-automated and automated 3D plaque volume assessment tools that are available on majority of the current scanners, which quantify all the categories of the plaque and give you a total plaque volume. And it is recently, a lot of total plaque volume has also been associated with increased risk of cardiac death. You must understand that we are not talking about coronary stenosis till now. We are just talking on the plaque morphology and how important it is nowadays just in predicting whether the patient can land up in acute coronary syndrome. And there are strategies which are being worked to do serial CT angiograms in patients who can benefit from primary prevention strategies, which could involve lifestyle changes and introduction of statins. It has been attributed that majority of the MIs that happen because of non-obstructive coronary plaques on a previous angiogram or on a baseline coronary CT. So it is very important to identify or look for these plaques, quantify them, write the plaque volume, mention the plaque characteristics, and which can help a long way in management of these patients. And if you have both the calcified and soft plaques with or without luminal narrowing, as you can see, this is a diffusely diseased vessel. Another important concept in total coronary occlusions is the enhancement of thrombus or linear enhancement within the thrombus. If you have a scenario of a chronically occluded proximal vessel, and if you can see linear enhancement in this vessel wall, it invariably means that this vessel can be dealt easily on transcatheter manipulations, and you can pass the guide wire through these plaques if you see a tumor, if you see the linear enhancement within the thrombus. And in this case, you can also appreciate subendocardial ischemia that is setting in. And on the color 3D map, you can see.
Good evening, everyone.
The anastomotic points and the distal vessels beyond. You need to stabilize pulse rates in patients with CABG as well. Coming on to coronary stents, this has been an area of challenge with single source scanners in recent time, and the hallmark and the main determining factors are what is the diameter of the stent that has been placed. All the stents that we used to see in 2004-5 were thick strut stents, and it was impossible to see the vessel within the stented lumen. However, with presence of drug-eluting stents and bioabsorbable stents, the things have become much better, and the overall sensitivity and specificity of CT in picking up coronary in-stent diagnosis, in-stent complications has improved. CT, this is an example of a normal in-stent lumen, and this is an example of a edge restenosis which has occurred. This is not an uncommon finding if you see the stent issues with stent placement or with patients who continue to have dyslipidemia or risk factors even after stent placement. And this is an example of an occluded stent. Another area of interest which I found in the article, I have started using it recently, is measure the density of the vessel and compare it with the aorta before and after the stented lumen. This can also give you a fair amount of idea about what is the in-stent diameter in such scenarios. And CT can also be used for evaluating post-stent complications, whether it could be aneurysm or a stent rupture, like this is a vessel rupture you can see on later on delineated on the cath angio. CT is also being used for cardiac function analysis, although it is not much needed. Patients already have their EFs and end-diastolic volumes worked up on the echocardiograms. LV wall motion can be seen, but for this you need to have contrast on all the older scanners within the right heart, and you need to do a manual tracing both in the diastole and systole phase. You need to do a retrospective gating, scan the patient throughout the coronary cycle, and then you can plot these. A lot of softwares are available where you can look at LV wall motion abnormalities. And this is just an example of an akinetic segment which is not moving in diastole and diastole secondary to a coronary infarct. Now, myocardial perfusion on CT is coming up with a lot of scanners which are using dual energy protocols or dual source scanners and scanners with 256, 320 and 640 slice systems. Our experience with myocardial perfusion is limited. Typically, myocardial perfusion is performed by giving adenosine and performing the scan at rest, followed by scanning at rest, and then comparing the myocardial perfusion in both the phases. Another thing that is important now is providing more functional information to the stenotic anatomic segment in a coronary artery is fractional flow reserve derived from CT. Classically, it was performed using a catheter angiogram. It is basically that all the data set of a CT coronary angiogram is fed into the systems, and it provides a non-invasive prediction of the coronary flow, especially into the segments which are beyond the vessel. And a cutoff of value of 0.8 has been suggested. If the FFR CT value is more than 0.8 in a post-stenotic segment, it usually means that the stenotic segment is not hemodynamically significant. However, values less than 0.76 have been reported to be of hemodynamic significance in the literature. Now, a lot of AI and machine learning is coming onto the cardiac CT. It is basically intended at pushing in all the workflow and all the data set into the machines, and they will automatically predict what is they will segment the vessels, they will map all the coronary cardiac structures and predict calcium scores within a fraction of a second. There are work that is going on that if you have done a non-contrast CT of the chest, which is non-gated, suppose for radiotherapy planning or an HRCT chest, you are able to derive calcium score information from those scans as well. And looking at the data set, looking at quantifying the plaques, it can predict which are the patients who are at high risk for developing myocardial infarction. And in a similar manner, it will be able to predict all the myocardial perfusion scores in a very reproducible manner, even in scans which have been done at very high rates. Now, another area of interest on evaluation is for coronary artery is looking at the anomalies. And the most common variant that you see in most daily practice is myocardial bridging, which means dipping of the coronary vessel into the myocardium. It is also called as intraventricular tunneling. It is usually seen in left anterior descending artery, but can rarely be seen in the RCA as well. And usually these patients are asymptomatic. However, areas of coronary vessel proximal to the myocardial bridge are more commonly involved with plaques because of stasis that occurs in the segments during the ventricular diastole, ventricular systole. Another important coronary anomaly which you should look at is origin of the right coronary artery from the opposite ostium, whereby it has an interarterial course and can get occluded in patients who undergo a lot of stress or running or jogging. Now, this has been reported as a common cause of sudden cardiac death in few situations. Another very rare anomaly is presence of a single coronary artery or origin of coronary arteries from the pulmonary artery. You can see that the left coronary artery is arising from the pulmonary vessel in this case. Before the advent of CT, it was considered pretty rare, and it was believed that L-kappas do not go into the adulthood. But as the years have passed, you see a lot of case reports of anomalous origin of coronary arteries from pulmonary vessels in adult populations as well. Apart from this, there are a lot of non-coronary applications where you need to do an ECG-gated scan, especially in mapping of pulmonary veins in patients who have to undergo RF ablations in cases of atrial fibrillation. You can have supernumerary or single pulmonary veins on either side, which need to be mapped prior to the intervention. This is just an example of a post-intervention complication. You can see a cardiac pacemaker placed in situ. The patient developed hemoptysis. And you can see this is a hemorrhagic mucosa in the left main bronchus. There is some ground glassing in the left lung. And you can see that the pulmonary vein has got occluded due to RF ablation performed because of the for AF in this patient. And the patient later on developed pulmonary arterial hypertension and hemoptysis. Cardiac valve assessment is coming in a big way, just like in MR. And you can see clearly the aortic and the mitral valves. Transarterial aortic valve replacement is now as being performed at a lot of tertiary hospitals, and we are a part of a protocol on TARVI whereby you need to do a ECG-gated scan of the chest, look at the valve. There are a lot of softwares that are available for that, and then you do a non-gated scan through the thoracoabdominal aorta. Recently, transarterial mitral valve replacement is also coming into being, and CT will be used for that in future. This is just an example of aortic stenosis with the improper closure of the valve during ventricular diastole. Now, there are certain limitations to coronary CT. If the patient moves, if the coronary images, the spatial resolution of your scan is not good, if there are motion artifacts, you may over-report a coronary stenosis. It still remains a challenge with a lot of single-source scanners to image heavily calcified plaques and smaller coronary stents with thicker structs. And there is always an inherent increase of risk of radiation exposure, although now with prospective gating or a single cardiac scan cycle scanning, the risk of radiation exposure is going down. So to summarize, coronary CT has evolved as a very highly sensitive and a specific modality in evaluation of coronary artery disease. Plaque characterization is improving as the spatial resolution is improving. Functional tools are adding to this anatomical information, and it must always maintain patient's heart rate stable in order to lower down radiation during the coronary scan. Thank you for your attention. Thank you.
Thank you, Dr. Sandeep Bora, for the excellent talk on cardiac CT, the basics and the advanced applications. I hope this is a very useful session for all our radiologists as well as the radiology residents. And we look forward to question and answers on this topic at the end of the session. And now, as we proceed further, I request Dr. Bhavin Jankaria, who everyone knows as a very good teacher and an expert in cardiac MRI. So I invite Dr. Bhavin for his talk on fundamentals, the basics of cardiac MRI. Sir.